So I'm very excited, as I said, to introduce our next speakers from the University of Washington for this session entitled First Episode Psychosis Care in Washington State, What You Need to Know. Our speakers are Dr. Akansha Vaswani-Bye and Dr. Maria Monroe-DeVita. And this is a topic that we get a lot of questions about. And so we are really excited to bring you these two experts and to learn from them today. And again, as Tom mentioned, if you could just leave yourself muted during the session, and then we know it's a really short session and there's a lot to cover. So feel free to drop questions in the chat. And then if we have time at the end to take some questions, I would love to be able to share some of those with the presenters. So without any further ado, I will turn it over to our two presenters.
Great, thank you, Katie. Can you hear me okay? Everything coming through? Okay. Go ahead and advance my slides here. So thank you so much for having us today. I have to say, I think I speak for both Akansha and myself to say we're both honored and humbled to be here as a part of your Day of Hope. Akansha and I both work with our Washington State New Journeys teams. So we'll tell you a little bit about both that work, as well as our work with families. Akansha is going to share a bit about Psychosis Reach and Family Bridger. We come to you, as Katie mentioned, from University of Washington. We work with the SPIRIT Lab, which stands for Supporting Psychosis Innovation Through Research, Implementation, and Training. And we support a lot of training and continuing education for providers within the Washington State area, as well as across the country, focusing on CBT for psychosis, first episode psychosis, assertive community treatment, and other evidence-based practices for this population. So again, we'll focus today on early psychosis resources across our state so that you all have a better sense of that. And as Katie said, we're hoping that we can have some opportunity to chat with you more and to answer any questions you have about any of these programs or about early psychosis in general today. So let's start first by setting the stage by talking a bit about the problem we're all facing in this particular area today. Each year, approximately 100,000 young people experience a first episode of psychosis. Many of these individuals and families go without care for long periods of time. In the US, the average duration of untreated psychosis, or it's also known as DUP, you'll hear me kind of reference that a couple of times, is more than 2 years. And this is in spite of the fact that the WHO suggests that specialty care for first episode psychosis start within 3 months of illness onset. Other than the obvious, here's also why that's a problem. Multiple individual and meta-analytic studies suggest that DUP is a strong prognostic indicator. Longer DUP contributes to more frequent relapse, a longer course of illness, and more profound disability. While a relatively low prevalence disorder, the burden of disease for psychosis and schizophrenia spectrum disorders in particular is pretty substantial. Psychosis is associated with high disability, accounting for a significant portion of Social Security expenditures with enormous personal and societal costs. And people who experience psychotic disorders are at higher risk of longer-term health outcomes and decreased life expectancy. Suicide rates are also higher, as are rates of homelessness and incarceration in this population. Okay, so that's the bad news, and I recognize that many people's lives, all of you who are joining us today, many of you or you know of loved ones who have experienced many of the things that I described today in these opening slides. Here's where I switch to the good news though, and that good news is partially rooted in a program called Coordinated Specialty Care. The term Coordinated Specialty Care, or CSC, was first coined in a seminal white paper by the National Institute of Mental Health to describe the evidence-based model for treating first episode psychosis. It's based in models originally implemented in other countries. In fact, the Assertive Community Treatment, or ACT model, various versions of that in other countries, particularly in Australia, Britain, and Scandinavia, as well as Canada, kind of demonstrated this particular model, but focusing on people with first episode or early psychosis. It leverages that same multidisciplinary, multi-component approach to first episode treatment. And as you can see here, systematic reviews and research worldwide shows significantly positive outcomes in the areas that you can see here as compared to treatment as usual. And again, the wealth of evidence suggesting the shorter the duration of untreated psychosis or DUP, the better the outcome, and vice versa, with poorer outcomes measured up to 15 years later when we don't intervene earlier. All right, so I want to tell you a little bit about then our new Journeys team. I'm going to switch to this particular version of coordinated specialty care, which we have in Washington State. It's actually based on a national model that was piloted many years ago called Navigate. And so we have kind of our own version that we call it here in Washington, which includes a program director who is typically the person who's providing education and support to families within the team. We've got a psychiatric care provider who is usually a psychiatrist or psychiatric nurse practitioner who's providing low-dose antipsychotic medication and other pharmacological treatment. There is also a case manager that's part-time with the team typically, providing that kind of outreach and support, as well as navigating any other kind of basic needs within the community, helping to kind of get access to housing, those kinds of things within the team. There is somebody called an individual resiliency training or IRT therapist, and that person is trained in CBT informed care. This particular type of intervention is based and rooted in CBT. It's called IRT. And this person is the primary psychotherapist on the team. And in the future, we're hoping actually this role can do a lot more around providing services within, particularly focused on co-occurring substance use disorders as well, given the high concentration of folks who kind of come in with co-occurring substance use disorders and substances that they're using at the time they come into the program. There's also a C specialist, which stands for Supported Employment and Education Specialist, focusing on either helping folks stay in school or get access to school, going into trade school, going into work, supporting work, that kind of thing. And again, really focusing on those outcomes I mentioned earlier, really helping to kind of get folks involved and connected to school sooner rather than later. And then there is a part-time peer specialist on the team who is a person with lived experience with mental illness themselves, providing education and support and peer-based services within the team. And again, the team also focuses, I just want to make sure it's clear too, this community outreach and education component, which is basically to kind of get out there to typical places who would provide a referral. So, pediatricians in the community, schools, but also looking at other community mental health agencies, inpatient services, wherever we think folks might be undiagnosed or not receiving services at the time that they're referred to the program. Really getting the word out there into the community is a huge component of the program. And these programs typically serve about 30 individuals for approximately 2 years, give or take. We do have some folks who are in services a little bit longer, and we do sort of see nationwide and actually worldwide more extension of those services beyond that 2-year mark. But right now, that's kind of the general time frame, or at least on average, that we're looking at in our New Journeys teams in Washington. Here's a map of where the New Journeys teams are located. So, and I just kind of want to walk you through a timeline here. We began implementing New Journeys in Washington in 2014 with the launch of our first team at Comprehensive Healthcare in Yakima. Then the next year, 2 more sites, one in Valley Cities in the greater Seattle-King County area, and the other at BHR and Thurston-Mason counties based in Olympia. Then 1 more team the following year at CMAR, Community Services Northwest in Vancouver, followed shortly by the BHR Grays Harbor team in that area. Let's see, are these all? Yeah, they're all advancing. Then in 2018, that was our biggest year yet, we implemented 4 new sites, including Catholic Charities in Wenatchee, Comprehensive Healthcare in Pasco, Ryther in Seattle, and then Comprehensive Life Resources in Tacoma. And then this year, we welcome 2 more teams, Frontier Behavioral Health in Spokane and Kitsap Mental Health Services in Bremerton. We also have 1 more sister team of note. That's what we call the STEP team, which is based in Seattle at Harborview. And while it's not an official New Journey site, STEP follows the same Navigate model of coordinated specialty care and continues and contributes to supporting early psychosis care in our state as well. Although rumor has it that the STEP team will become an official New Journey site in the near future. And what that means is just more resources to that team to be able to hire the full cadre of professionals I mentioned just a bit ago to you within that team. Here are the admission criteria for New Journeys. So the age range is pretty wide, ages 15 to 40. I would say most of the people that we serve within New Journeys are around that 15 to 25 age range. Occasionally, we get referrals into that program these are folks who might be a little younger than 15, and we ensure that we do proper differential diagnosis and ensuring that, these are really folks that we're intervening a little bit earlier, but they do meet those criteria otherwise. And so we'd rather that they get the care sooner rather than later. As I mentioned earlier, that contributes that earlier, that reduction of duration of untreated psychosis is just huge in terms of impact long term. Symptoms need to be present at least a week and within a 2-year time frame. And so we're really kind of targeting what has been defined nationally and internationally as that first episode period. What that doesn't mean is that it's just one time that they experience those symptoms. So sometimes that the terminology, I think, gets a little confusing when people think, okay, first episode, that means after that first time, they can't get into this program, but that's not true. We extend it out for a 2-year period. It has to be kind of within that 2-year period to get the resource within New Journeys. And then here's a list of the primary diagnostic criteria. Typically, those who experience a range of symptoms and meet the criteria for schizophrenia, spectrum disorders. Exclusion criteria don't include what we call affective psychosis. So a mood disorder, that would be bipolar disorder with psychotic features, or major depression with psychotic features, or pervasive developmental disorders or autism spectrum disorders. Although I will say that we do have pretty high comorbidities. And so we do have some folks that we are serving within these programs who may experience autism spectrum disorders as well as a schizophrenia spectrum disorder. Another exclusion criterion is a documented IQ less than 70. And then the psychosis cannot be due to substance use or intoxication or a medical condition. And so we'll often look for kind of criteria and documentation or evaluation that will help to sort of justify that and to better understand what's going on with the person. So many of these teams will, be equipped with and have access to many of the resources we provide at University of Washington to get a proper differential diagnosis and potentially additional evaluation through our CAPS services, which stands for Central Assessment for Psychosis Services. I'm going to turn it over to Akansha here in a minute, but I just want to make sure that you also have access to our New Journeys website, which includes all the locations of all of those teams I mentioned earlier. There's a place also on this website to do a direct referral to New Journeys, and then someone on the other side of it would then connect families or individuals to whatever New Journeys site is in their area. It also includes all of the websites for each program that I mentioned earlier, so that you can just go right into, a direct referral to, for example, BHR in the Thurston Mason counties, for example. So I'm going to turn it over to Akansha from here and have her tell a little bit more about our family programs in particular that we support through our Spirit Lab.
All right, I'm going to share my screen, and I can see that we're getting some questions, some great questions in the chat, and hopefully we can get to them. I can run through my slides and we can get to them because there's some great questions coming in. Yeah, can everyone see my slides? All right. It's my slides and not my notes.
Yes, it looks good.
Good.
Okay, thank you. Thank you. So, like I want to just say before I begin speaking that, like Maria said, such an honor to be here, with this audience. And I know that there's a lot of wisdom and experience in this room as well. Just want to acknowledge that before I begin. So, Maria shared a little bit about coordinated specialty care. And before I go into some of the family programs that we're offering at Washington State, I want to draw your attention to what our National Schizophrenia Treatment Guidelines say about psychosis care. And the evidence tells us that recovery is most likely to occur when individuals get care that's holistic, multidisciplinary, evidence-based, and culturally sensitive. So these are elements, as you saw in coordinated specialty care, that are indicated for recovery from psychosis. And as you can see here, family interventions for psychosis is an integral part of good treatment. And our team is currently working on 2 projects that I'll be talking about. One of them is called Psychosis Reach and the other Family Bridger. And I think what's unique about both of these family programs is that they go beyond just providing families with education and are centered on providing families with skills, especially communication skills and reconnecting with their loved one, providing them with resources within their communities, and supporting their own health. So in other words, self-care. Both the programs, and I'll speak a little bit about them, they differ in their scope and how they're delivered. But our goals are really to empower family members and connect them with other families who have navigated similar territories. And so our idea is to build communities of support while navigating a loved one with psychosis. And another important point to note, about our family programs is that we collaborate, we strive to collaborate very closely with family members with lived experience in the implementation of our models. And, I know that some of them are on the call here today, so I'm grateful for everything that they provided us in the development of our programs. So before I describe the programs, I just want to make, this sort of feels like preaching to the choir, but just want to kind of make the case for why it is so important for us to build programs that focus on family. So one is that, the evidence shows, there's several papers that talk about how caregivers have a positive impact on recovery. So we see things like better treatment outcomes. So treatment that is provided in, sort of medical settings is more effective. There are fewer hospital admissions and reduced relapse rates, shorter stays in inpatient, overall improvement in individuals' quality of life, better social functioning, as well as engagement with treatment teams, more likely to better perform at work, and as well as reduce substance use. And I think a huge one, Maria had referenced the higher mortality rates, is that there's reduced mortality rates when there's caregiver involvement. So caregivers have a huge positive impact on recovery. The other thing is, that we know, given the context of our mental health system, that caregivers are often the sort of frontline workers. They're spending an equivalent of a full-time job in caregiving activities. And again, this is like preaching to the choir here. And this is particularly true when families live far away from mental health clinics. What all of this means, of course, is that caregivers are providing more support than the mental health system, but they don't receive as much support or training themselves. So I also want to point out that, collaboration, unfortunately, between mental health and providers is not the status quo. Involving families in treatment is recommended, but we find, again and again, that a majority of adults with psychosis who are involved in treatment do not have a family member involved in their care teams. And this is a critical gap in our services. So the status quo of not involving family members has harmful effects both economically and emotionally on caregivers. We see significant economic impact, including a loss of work days, and even potentially the need to relinquish paid positions in order to have the capacity to care for loved ones. And we also see increases in emotional challenges such as symptoms of depression and anxiety, as well as just dealing with the effects of burnout. So again, I'm saying all of this to kind of drive home the point that involving caregivers is important and integral, and caregivers need support from our system to help better care for their loved one, but better care for themselves as well. So I'll first speak about Psychosis REACH, and REACH stands for Recovery by Enabling Adult Carers at Home. And this is a relatively new training program. We began this program in 2019, and we're currently scaling it up in the United States. Because of the pandemic, we're able to kind of offer it now outside of Washington State as well. And one of the unique things about REACH is that it takes the training program outside of the clinic and provides training to family members in evidence-based strategies that are rooted in cognitive behavioral therapy for psychosis principles. So the implementation lead for this project is Dr. Sarah Kopelovich, and our collaborators have been Dr. Douglas Turkington, who's a psychiatrist from Newcastle University, and Dr. Kate Hardy, who's a psychologist at Stanford. And Maria and I are also involved in this program through the Spirit Lab. So I'll tell you a little bit about REACH. So as I said, psychosis takes the family into, takes the intervention out of the clinic directly to the family. This is a little bit about how we do it. It's a tripartite model. And what we do is provide family members with recovery-oriented psychoeducation that kind of separate facts from fiction, call out myths and misconceptions about psychosis. We try and provide families with accurate information and share the latest research in an effort to ground their hope in empiricism and evidence. And we share with them a culturally informed cognitive behavioral model for understanding psychotic experiences. And that includes educating families about what our national psychosis treatment guidelines prescribe as standard of care, so that our families can become informed consumers and consumer advocates in working with treatment teams. The other important component of our model is caregiver self-care. We emphasize that CBT and self-care skills are just as critical for family members as they are for their loved ones. And finally, we provide coaching and information about CBT skills that we call the first skills, and these are essentially communication skills that will help family members support loved ones who are experiencing psychosis. And the idea is that they can execute this without, a lot of training. We also, clarify roles and boundaries. We know that REACH is not intended to put family members in a position where they're administering therapy. It's not intended to replace treatment. The analogy is the same way that we teach parents how to check blood sugars and operate an insulin pump for diabetes, and that is not intended to replace, the treatment team for a child or adult. Our trainings are, a space where we offer, we don't offer individual advice therapy to family members, but what we're trying to do is empowering family members with information and skills and creating a space for them to come together with other families for connection and co-learning, and hopefully better support their loved one. So this is the acronym for the skills that we teach. It's sort of a play on the idea of, fall back on these skills first. And if you're interested in learning these skills, I'd encourage you to attend one of our art trainings and learn more about it, I think, from family ambassadors. And I'll describe what those are in a minute, who those are rather. So our current training model, if you're interested in attending one of our REACH programs, is that family members attend a self-paced online course, which is about 5 hours. They get access to a learning management system. And they have access to these videos as well as resources, in perpetuity. So they can go back and access the sort of psychoeducation piece, the rationale, and information about the first skills. And once they go through that online course, we host a live training event that's about 3 hours every couple of months, where we provide demonstrations, role plays, and skills practice, and live, we answer questions live. And again, it's a kind of community Zoom forum at this, sort of like we are here today, where they can get kind of hands-on experience in looking at some of these skills. And finally, once they've completed the training, they have access to community board where they can connect with other family members, ongoing resources that we try and update. And I think one of the roles that we see as most pivotal that has emerged from Psychosis Reach is the family ambassador role. And the family ambassador is a family member who's been through Psychosis Reach as well as additional training in training other family members in implementing these skills. And I know that some of them are on a call here with us today. So this is sort of a peer model where families can connect with other families who are kind of further along the journey, and they can support them in implementing these skills within the context of their own family. So it's a kind of peer-to-peer, family peer-to-peer model. And we're trying to kind of increase the number of family ambassadors we have with time. So what does a family ambassador do? A family ambassador, provides emotional support, skills coaching in the first skills, as well as teaching of the CBTP informed first skills. And they connect with families in several ways, in group settings or one-on-one. And one thing that we always like to stress is that family ambassadors are not expected to act as case managers, therapists, or family navigators, or counsel families in de-escalation techniques or address other safety issues. But they are someone who's kind of a support person who can provide some knowledge and support in implementing these first skills to other families. And we've experienced a lot of really great feedback in implementing this model of connecting families to one another. So the other program that's newer and we're actually is still in development, we're implementing a pilot right now, is the Family Bridger program. And the Family Bridger program, was emerged through a working group through Chad's Legacy Project. And the idea was to develop a Family Bridger role. And the idea was to have a family member with lived experience present in inpatient settings, similar to peer bridger programs that we see for individuals who are diagnosed. And the idea was that a family peer would meet families whilst their loved one was in an inpatient setting, because we learned from focus group meetings that providing support, family support early on would be very important for families who are first entering the mental health system and navigating the emotional impact of learning that a loved one has a serious mental health condition. So we conducted focus groups to learn from families what their needs might be. And the idea was that this Family Bridger would provide support to families for the first 120 days after hospitalization. So we conducted focus groups in several locations across Washington state to learn what families might need when they first enter the mental health system. And so what we learned was that, families wanted support in things like skill building, in terms of how to support their loved ones in symptom management and coping skills in navigating things like hearing voices or unusual beliefs, even, after medication has been instated. The other one was just interpersonal support, right? Having someone who says, hey, I've been in that same boat as you. The third was, evidence-based and recovery-oriented education about how there might be hope for the future, that education to provide information about what might happen next within the system. The other was advocacy, recognizing that when one is first in the hospital setting with a loved one, there's a lot going on emotionally, and you need someone to maybe, be there with you, listening when to things that you're not able to listen to at that point, and advocate for you. And finally, resource provision. What is out there in my community that can support me and my loved one as I navigate this journey? So, of course, COVID happened and we had to shift our scope. And because, if family members and peers, this particular role was not able to be implemented in hospital settings. So we shifted to a telehealth model, and we began piloting it with the New Journeys teams that Maria described a short while ago. So right now we've been working with 3 family bridgers and about 11 families. And the way it's set up is that families get access to 10 virtual or phone meetings over a 5-month period. And, right now it's not a paid position like the peer bridger, but our hope is to be able to enter the formal mental health system and actually employ family members as peers within the system. So, this is what I was describing in kind of the difference between Psychosis Reach and Family Bridger. Psychosis Reach kind of takes the intervention outside the clinic, and then our Bridger model is thinking about ways to partner within the mental health system. And so we're slated to complete the pilot by the end of the year. But I just thought I would share some feedback that we've got from family members involved in this program. You can see here that one of our family members says how much the program has relieved stress. Conversations with the family bridger taught her how to take one day at a time and give herself grace. And some days and sometimes I'm going to be a good mom, a really good mom. Other days, not so much. And that's okay. And it's okay to struggle and just check in and say, okay, well, these are the things that went well and these are things not so well, and learn from that and move forward. So, I think across our programs, I think normalization is such a huge component of what we do, and what we've seen is really, really helpful. So I'll stop sharing my screen here.